هنتكلم النهارده على السلكشن اوف ادفانسد ثيرابيز. احنا النهارده بقى عندنا اكسبيرينس ان احنا نستخدم البيولوجيكس الجديده زي الفيدوليزوماب وزي الاستيكينوماب، والنهارده بقى عندنا التوفاسيتينيب، وبقى عندنا بيشنتس كتير ماشيين عليهم. الى حد ما جمعنا شويه اكسبيرينس، والى حد ما بقى عندنا داتا ممكن نعرضها عليه. disclosures. اول حاجه ان احنا ليه بنختار البيولوجيك، او ايه التارجت بتاعنا ان احنا نعالج العيان ليه؟ كان في الاول ان احنا بنفكر في الكلينيكال ريميشن، ومبدئيا دي اول حاجه بتهم العيان. انا مش عايز يكون عندي اعراض. بدات ترتقي المطالب شويه انها تكون اندوسكوبيك ريميشن، ان انا اخش في المنظار بتاعي الاقي ان الدنيا الالسرز راحت، او الدنيا خفت، او الالتهاب قل عندي. بعد كده ان انا عايز اكومباين الكلينيكال مع الاندوسكوبيك ريميشن، متجهين نحو الديب ريميشن، واللي بيوصل دلوقتي يعني اقل من 30% من المرضى بتوع الاي بي دي اللي بنعالجهم، وده انجاز. ونفسنا يكون بعد كده ده الاتجاه، وده اللي شغالين عليه الاستاديز دلوقتي، ان احنا نوصل احنا نوقف الديزيز تماما.
Please, Dr. Mohamed, try to keep it in English, please.
Okay. So when choosing a first-line biologic, we have to consider a plan for lifelong treatment. We want the patient to continue on our treatment, and to put in mind that we will keep on this drug for a long time, for a lifelong time. So I have to think of the inflammation control, the disease regresses or no disease at all, the symptoms, mucosal healing and fitness and metabolic health, the cardiovascular health, and of course, an increased quality of life, putting in mind that the expectations of the IBD patient in general is a little bit low. So we have to keep on monitoring the patient quality of life and his productivity to ensure a better productivity. If we are talking about the conventional treatment, that the conventional treatment is the old treatment, the tried treatment, the safe treatment. We can see that infliximab started at 2003 for the CD patients, and then we had the adalimumab, the vedolizumab, the ustekinumab, and tofacitinib. And next year, starting from next year, we have new molecules. Maybe some of us have tried these molecules through clinical trials, like the UPA and the risankizumab, and very soon the etrozumab. So we have to be fully aware of the available treating options and the available biologics, and how we can manage and deal with them. In selecting the proper therapy and the proper biologic, we have to put in mind two aspects. Number one, we need the fast induction, but we have biologic with fast induction and low sustainability. The patient starts good start through the induction with the symptoms regressing, and then after some time, the sustainability, the maintenance of the drug decreases. Or we can choose drugs that has slow induction and high sustainability. The good thing of sequence that we can get a synergistic mode of action, a fast induction and a high sustainability, and that of course what all the studies are going through right now. How do we optimize the treatment decisions when considering advanced therapy sequencing? We have to determine the right first-line therapy that sets up our patient for success. We have to consider all the common circumstances and how the patient become adherent to the treatment with good efficacy, of course, and good result and safety profile. So we have to consider multiple points. Number one, does the first-line biologic therapy affect the efficacy of subsequent treatments? That if I give a single treatment or a specific treatment right now, will it affect the second biologic I give in case that the patient lost response on the first biologic? Does the first-line biologic hit the right target of disease pathophysiology? And also the mode of action does affect the subsequent treatment. I have to see if the disease is concise to the GIT, or if there is another organ or an associated disease or an extra intestinal manifestation. I have to consider when selecting the biologic, if it's systemic or it works as gut selective. And how does the safety profile of the therapy influence patient acceptance of treatment? I don't give a drug to a patient for a long time that may cause adverse event or serious adverse events, which will affect the context of patients' lifelong treatment. And does the disease duration and disease severity impact efficacy of treatment? This is a very important point, because as the disease stays for longer time, the controlling of this disease is affecting. And that's the point where we talk about the window of opportunity where we can stop the activity of the disease before developing side events or developing the complications of the disease itself, like in CD, stricture, narrowing, or fistula formation. So how do we decide the sequence of therapies in IBD? We have three main pillars. The first one is the efficacy. Is the first line efficient? The second line and the comparative. Number two, the safety. What do the data tell us about the safety profiles of biologic therapies may affect sequencing? And finally, proposing a sequence of biologic therapies where we can combine the previous data with the recently published data to find the best sequence for the patient in a precise way or a treat to target way where the patient shares with me the decision of treatment. Which therapy and when? Based on efficacy prior anti-TNF therapy, starting ulcerative colitis. If we look at the ULTRA-2 with the pivot study of the adalimumab, which measured the patient's clinical remission response and mucosal healing just after induction, we'll find that the anti-TNF naive patients who never started biologics before showed a high response. We can see here the delta of the clinical response is a big difference, 20, that shows a big difference. And if we see at the TNF exposed patients, we will find it a little much less. We can see here 20 and here it's 8, the difference in clinical response. And we have to put in mind also that the patients on adalimumab, the previous treatment was infliximab, so a little bit the mode of action is the same, so it's expected to find the anti-TNF exposed patients when they start adalimumab, they will get least results. And if we can see at the vedolizumab, we will find also a very big difference in the Gemini 1 in the patient anti-TNF, anti-TNF naive between the patients on vedolizumab and the control. And of course, in such studies, the control patients are on treatment. They are not placebo. So we find a very big difference. And when we look at the TNF exposed, we'll find the difference much less than the naive patients, which is unsatisfactory. And if we look at the octave 1 and 2 for tofacitinib for ulcerative colitis, we will find that there is no difference between the naive anti-TNF naive and the anti-TNF exposed. We can even see that the anti-TNF exposed patients saw better difference between the control and the patients on tofacitinib, and much, it's a little bit bigger than 11.5 and 11.2, and here 16.8 and here 15. So that's maybe why they can say that tofacitinib is preferred or better or must be given to as a second line after TNF failure, after biologic failure. If we look at ustekinumab for ulcerative colitis, also we will find a big difference between the clinical response here and the control, and also in the biological failure, we'll find a big response. So the ustekinumab is responsive in both the biologic failure and the biologic naive. So we have a cover of 2 good molecules that can cover patients with a biologic failure and give patients better outcomes. So similar confidence for each biologic. For Crohn's disease, we can see that the Gemini trial for vedolizumab showed a good clinical response. We can see statistical significance. However, there was no statistical significance in the CDAI 100 response. And that's why they developed the Gemini 3 study, where they compared the anti-TNF failure with the overall population. And we find statistical significance between the patients on vedolizumab and the control after week 6 and week 10, showing that there's good results of vedolizumab for CD also. The Gemini 2 and 3 studies, when they compared the symptom relief and the response in patients, they find that the symptoms started to regress, and there is a response after only 2 weeks. So that is very good in both the TNF naive patients and the TNF exposed. However, of course, in the TNF naive, there is a better results and better response to treatment. If we compared all the available pivot studies for the available biologics here in Egypt, we'll find that there's a lot of criteria which is not the same, and which does not have the same endpoint. And even we can see that the CD duration has a lot of difference between studies. So we can do a comparative analysis between studies to find the best drug. And this is a gap which says that we need to develop more head-to-head studies to compare the results of different biologics. In CD, the anti-TNF therapy with adalimumab induced mucosal healing at weeks 12 and 52. So 12 is after nearly after the induction, and 52 after 1 year. We can see that the mucosal healing after the induction was not that good, but however, after a full year, all the criteria became better with adalimumab. So we never judge the response of the patient just after the induction. We have to stay for some time. Vedolizumab induced endoscopic remission and response and complete mucosal healing at week 26. By the way, remission means that we have improvement of the endoscopic picture, less than 4 on the CSS score, and response is more than 50% improvement at the baseline. And we can see here that the Versify showed even that the patient's TNF naive showed better results than anti-TNF failure. However, we have to put in mind that the mean duration of the CD patients in this trial was 11.5 years, which means that these patients are very difficult to be controlled. And we can see here also that the complete mucosal healing, i.e. no ulcerations at all, is 15% of the patient, and complete mucosal healing less than 2 centimeter size of ulcer in SCD shows 28%. Nearly a third of the patient showed the response on vedolizumab for CD. The Versify showed also, and this is very important, that when we treat the patient early, when we get the patient early in the disease and control it, we find much better response to the disease. You can see after 1 year, 37.5 patients responded, and patients after 7 years of diagnosis, only 7.1%. So we have to consider such molecule in patients with early will get better results. And as we seen previously, that even patients on adalimumab showed better results when they were diagnosed early. And if we look to the immunity, the study of the prolonged study of ustekinumab at week 44 outcomes for CD, we will find good response for ustekinumab in Crohn's disease at both doses, the 8 weeks and the 12 weeks. However, a slight better results at the 8 weeks. Efficacy by prior anti-TNF therapy Crohn's disease. Adalimumab showed reduced efficacy in anti-TNF exposed patients, even in longer duration. And if you can see here, the anti-TNF naive patients after 6 months, there was a good response, 29 delta difference, and only 16 for patients who are TNF exposed. And after 1 year, even it was a little less, 28 for TNF naive and 21 for TNF exposed. The Gemini 2 showed that clinical remission outcomes for vedolizumab therapy after 6 months, after 6 weeks, 1 year. We can see that the TNF naive patients showed better clinical remission after the induction, and after 1 year showed also a big difference. However, in exposed, there was good improvement in CD. However, it was little less than the anti-TNF naive patients. The Unity 1 and Unity 2 for CD, ustekinumab for CD at week 6 and 8 showed also the good results, very good results for the anti-TNF naive population, and also good results, but it was also less in anti-TNF refractory population. The efficacy of by prior vedolizumab therapy, if we started with vedolizumab, and we have a paper that was published during introduced during the UEG week last year. It was talking about the clinical effectiveness of first-line anti-TNF therapies and second-line anti-TNF therapies post vedolizumab. And we can see from the evolved studies, if we look at the p-values in all criteria, we'll find that there is no difference before and after vedolizumab when we start anti-TNF. So the anti-TNF affected the results of vedolizumab when we started a second line. However, when we started at first line as with vedolizumab, then switched to anti-TNF, there was no difference in the efficiency of the anti-TNF. So we will give the patient more better results if we started first line with vedolizumab, even if we have to use anti-TNF later on. The second line anti-TNF after 3 months and 6 months in CD showed clinical remission, only statistical significant difference in the clinical remission, both 3 months and 6 months. So comparative studies of first-line use of biologics. And if we look to the also results from the EVOLVE studies, we can find that the adherence of the patient to vedolizumab was the best. And we can see here all criteria discussed in the EVOLVE study comparing these drugs, and we find that the patient adherence in the vedolizumab was better. The patient favor to continue on vedolizumab, so we keep on following the patient for longer time. The vedolizumab and the anti-TNF show comparative effectiveness in first-line biologic settings over 24 months and in CD also, and we can find patients are continuing their treatment for the vedolizumab for a longer time than the anti-TNF. And if we look here at the VARSITY study, which is the first head-to-head study done between the vedolizumab and the adalimumab, and we can find here that overall primary endpoints was reached favoring the vedolizumab more than the adalimumab, and even in both the naive, anti-TNF naive and anti-TNF exposure, the results with the vedolizumab was much better than the results with the adalimumab. We also find higher rates of endoscopic improvement between vedolizumab and adalimumab, and we can see here that the overall was higher, and even in both the anti-TNF naive and anti-TNF exposed, much better results with the vedolizumab. And when we compare the results, we find that both the clinical remission curves meet each other at 4 weeks, just after the induction. However, later on, the vedolizumab is superior to the adalimumab in the results of the IBD patients. So based on safety, and of course, we know that vedolizumab is a gut selective biologic, so we don't affect the systemic immunity of the patient. So logic-wise, we can find that the adverse events and the side effects presented by the physicians or reported by the patients are much lower with vedolizumab in UC. And we can see here, of course, that the serious side events and adverse events was less than anti-TNF with vedolizumab in both the ulcerative colitis and the Crohn's disease cases. So according to what I discussed now, we can see that we have to give the patient opportunity, and starting with the advanced biologics before the anti-TNF gives the patient another option, which is using anti-TNF as a salvage treatment if the first time or the patient lost response on other biologics. Vedolizumab is a safe drug we can start with, and we can find that we prescribing the vedolizumab to patients with ulcerative colitis and Crohn's disease both, but mostly to ulcerative colitis anti-naive TNF patients, we get very good results comparative to patients post anti-TNF treatment. Thank you very much.
Thank you, Dr. Khurshid, for this nice presentation. I will ask one question before shifting to the next session. Can you hear me?
I can hear you, Ashraf.
So you recommend now from your research that I understand that we have to start to cancel the anti-TNF totally and start with Vedo, and if we fail on vedolizumab, we have to shift to anti-TNF. Any study recommend shifting from Vedo to anti-TNF? Any study? Do you have an idea about study of that?
I just showed one study now, but however, Professor, we can't put a rule for starting which biologic. Every case we have now the precise medicine and how we select the biologic according to the situation of the patient. If the patient is severe, if the patient is diagnosed earlier, diagnosed few years more than diagnosed, just diagnosed. If the patient have extra intestinal manifestations, we have to select the biologic according to the situation of the patient. However, if we started with vedolizumab, we can see as Bressler's and as the results of the evolved study, we have the option of using other biologic later on and not waste the good mode of action of the anti-TNF later on. We're still giving the patient more option to be controlled on if the vedolizumab did not show results.
Okay, thank you.
Thank you very much. We have